Hi everyone, thanks for tuning in to this virtual talk. I want to thank Doctors Boutros and Champagne, as well as Sages, for the invitation to speak here about this important topic. I have no relevant disclosures or conflicts of interest. Diverticulitis continues to be a major healthcare problem in Western countries. Annually, in the United States alone, there are over 2.7 million outpatient visits and 200,000 inpatient admissions for diverticulitis at a cost greater than $2 billion, and the incidence of diverticulitis is only increasing. Over the years, the natural history of diverticulitis has been fairly well described. We know that among those with diverticulosis, probably less than 5% go on to develop one or more episodes of diverticulitis, with the majority, 85% or so, being uncomplicated, defined as the absence of a free perforation, abscess, stricture, or fistula. Historically, acute uncomplicated diverticulitis had three main pillars of treatment: antibiotics, some form of bowel rest, and hospital admission. And this was how diverticulitis was managed for years on end. But over the last decade or two, all three components of management have been challenged in some way, shape, or form. And one can argue that none of these three should apply routinely to patients with uncomplicated disease today. But antibiotics in particular have garnered a lot of attention, probably because of their recognized consequences and the emphasis placed nowadays on antibiotic stewardship. So let's begin by asking ourselves how and why antibiotic therapy became the default management of uncomplicated diverticulitis in the first place. Much of the link between antibiotics and diverticulitis is rooted in the long-standing but unproven pathophysiology of how a patient goes from having uncomplicated diverticulosis to an episode of inflammation. As early as 1904, surgeons believed that fecal stasis was the underlying mechanism leading to diverticulitis. Stasis within a diverticulum caused mucosal abrasions, followed by the infiltration of fecal microbiota, and ended in inflammation and microperforation. And like many pathologies in general surgery that involve luminal obstruction, stasis, and perforation, antibiotics were thought to be needed. However, our understanding of diverticulitis and its pathogenesis has since drastically evolved, and currently, the proposed pathophysiology of acute diverticulitis is a complex interaction between diet, lifestyle factors, genetics, chronic systemic inflammation, and the microbiome, leading some researchers to propose that diverticulitis may even be a type of inflammatory bowel disease. And as this research continued to emerge, some began to question the routine administration of antibiotics in the absence of perforation. And let us not forget, antibiotics are not benign. Just like the family doctor who has to fight off patients wanting antibiotics for their cold, we too need to exercise our clinical judgment, understanding that antibiotics have a number of negative consequences, such as antimicrobial resistance, adverse effects including secondary infections like C. diff, and healthcare costs, to name a few. So with that in mind, let's review some of the evidence on non-antibiotic therapy to see if the outcomes justify their avoidance. This table includes some of the original reports published on non-antibiotic therapy for acute uncomplicated diverticulitis. We won't spend too much time here because nobody's practice has ever changed based on observational data alone, but there are a few points worth discussing. First, it's noteworthy that all of the data comes out of Europe, and we actually still do not have any published data of non-antibiotic therapy out of North America. Second, people have been doing this for a long time, since the year 2000, and here we are 20 years later, still debating it. And third, even though this is observational data, the low number of patients who ultimately required antibiotics or who developed a diverticulitis-related complication is impressively low. The first randomized control trial was the AVOD trial, published in 2012. This was a multi-center trial involving 11 hospitals in Sweden and Iceland over an 8-year period. Their inclusion criteria, listed here, were fairly reasonable. The study was designed as a superiority trial and was powered to detect a 5% difference in the incidence of diverticulitis complications between the two groups. Of note, they did not limit the trial to patients presenting with their first ever episode, and roughly 40% of patients had a history of diverticulitis. They reported no statistical difference in complications between the two groups. Non-antibiotic patients had double the incidence of complications, but only a 1% absolute increase, which is probably clinically irrelevant, and we'll touch upon that more at the end of the presentation. Only 10 patients crossed over to antibiotic therapy, and all did well, and at 1 year there was no difference in chronic abdominal pain or bowel habits. Furthermore, on long-term follow-up, there was no difference in recurrence or surgery for diverticulitis. The Diabolo trial was published 5 years later. This study recruited in 22 hospitals in the Netherlands over a shorter time period, only 3 years, and their primary outcome was time to recovery, defined using the criteria listed here. Unlike the AVOD trial, Diabolo was designed as a non-inferiority trial, and their non-inferiority margin, with no real reasoning or rationale, was up to a 5-day increase in the time to reach full recovery in the non-antibiotic group. Unlike AVOD, they restricted their study population to patients presenting with a first ever episode, but they did allow patients with Hinchey 1B abscesses up to 5 centimeters into the study, which ultimately made up 10% of the entire study population. For their primary outcome, time to recovery was statistically similar between groups, although the non-antibiotic group had a higher median time to recovery by 2 days. The lower limit of their 95% confidence interval for non-antibiotic therapy was above 0.70, which meant that non-inferiority was achieved. And in their subgroup analysis of 42 Hinchey 1B patients, outcomes were similar. On secondary outcomes, complications and ongoing diverticulitis were both similar between the two groups, but again, you do notice a tendency for higher absolute numbers in the non-antibiotic group, especially for ongoing diverticulitis, which had almost a doubling in the incidence. And on long-term follow-up, there were no differences in recurrence, complicated disease, or sigmoid resection, although again, almost double the absolute incidence of sigmoid resection in the non-antibiotic group, driven mainly by elective operations. So based on this data, what do the guidelines say? Bear in mind that many of the societal guidelines were written before the second randomized control trial was published. The ACP-GBI said in 2014 that in general a course of antibiotics is recommended. ASCRS in 2014 agreed. The AGA in 2015 came out saying that antibiotics should be used selectively rather than routinely. And the World Society of Emergency Surgery said in 2016, even before the publication of Diabolo, that antibiotics can be avoided in immunocompetent patients. Now, one of the only benefits of delaying this talk to August was the publication of the updated 2020 ASCRS practice parameters, which now state that selected patients with uncomplicated disease can be treated without antibiotics. So you can definitely see a tendency towards less stringent recommendations for antibiotics over time. But of course, none of that really matters because everyone here wants to know what SAGES recommends. Well, in 2018, SAGES and EAES collaborated to provide evidence-based recommendations on the management of diverticulitis and tackled a number of controversial issues. Regarding antibiotics, the working group stated that in immunocompetent individuals presenting with acute uncomplicated disease, symptomatic treatment with antibiotics provides similar outcomes to treatment with antibiotics, and recommended that a trial of non-antibiotic therapy be considered in select immunocompetent individuals. Interestingly, only 59% of online voters from both societies agreed with this recommendation, with only a quarter saying that it would change their practice. The evidence was therefore re-presented at each annual meeting, respectively, and while EAS members re-voted to approve the recommendation, SAGES members did not, and I think this very much reflects practice differences across continents. So why the reluctance to adopt a non-antibiotic strategy, especially among North American surgeons? Is it just difficult to break such a strong surgical dogma? Are people concerned with the potential medical-legal ramifications of simply observing a patient with diverticulitis? Is there insufficient evidence? Are 2 trials too little? Is it the fact that there is no North American evidence? Or are there issues with the interpretation of the current body of evidence? We saw in both trials that there were small trends towards worse outcomes in the non-antibiotic groups, but a lack of power to show statistical significance. Even the authors of AVOD and Diabolo, in their recent IPD meta-analysis of their own trials, stated in the conclusion that some statistical uncertainty remains, depending on the thresholds of clinical relevance owing to small differences. Our research group at McGill University thought this was pretty interesting, and to try and address some of these considerations, we led a North American Delphi study, including patients and physicians from 18 states and provinces, to better understand what they may be willing to accept as a trade-off in order to avoid antibiotics in uncomplicated diverticulitis. And we found that physicians, on average, were willing to accept a 5-day increase in the time to reach recovery without antibiotics, and were willing to accept a 4% increase in persistent diverticulitis and a 3% increase in diverticulitis complications. And surprisingly, these opinions were echoed by patients. So there is some agreement that, albeit small, people are willing to accept some trade-off in clinical efficacy to avoid the potential consequences of antibiotics. We also surveyed the 55 physician participants regarding their concerns with using a non-antibiotic strategy. And you can see that it really is a complex situation. Not only are physicians worried about negative outcomes, but over half of participants also cited the lack of North American data, the fact that colleagues in neighboring institutions aren't using this approach, patient expectations to receive antibiotics, and medical legal ramifications, all as important considerations. So there's a lot that we as surgeons have to think about before we break from the mold. I want to end by reviewing a few interesting subgroups of uncomplicated diverticulitis. We know that uncomplicated disease comes along a spectrum and in many different flavors, and maybe non-antibiotic therapy isn't safe for everyone. First, patients with recurrent uncomplicated disease. These patients were not included in Diabolo, but made up 40% of the study population in the AVOD trial. In general, we know that patients presenting with a first episode of uncomplicated disease versus a second, third, or fourth do equally well in the short term. And we also know from the complicated literature that a patient's first attack is typically their worst. So I think these patients are fair game to avoid antibiotic therapy. What about patients with microperforation? This is considered uncomplicated disease by most. There are small series that suggest it is safe to avoid antibiotics in this subgroup, but it certainly wasn't the targeted study population in either RCT, and in other observational data, it is sometimes associated with higher risk for treatment failure. So I would probably recommend antibiotics in this subgroup. What about patients who are otherwise well but have a really high white blood cell count, or CRP? We're always taught to treat the patient, but nobody feels comfortable with an uncomplicated diverticulitis with a white count of 18 or a CRP of 200, fearing perhaps a missed abscess. In the AVOD trial, they actually had a subgroup analysis including these high-risk patients and reported no difference in outcomes with or without antibiotics. Conversely, a rising CRP is often in and of itself an indication to commence antibiotics in many of these prospective series. So I'm really not sure what to do with these patients. I would definitely think twice before avoiding antibiotics and would be tempted to give them, even though a high inflammatory marker doesn't necessarily equate to an infection. And finally, patients with small abscesses. These are actually considered complicated disease by most, and it was really only the Diabolo trial that included Hinchey 1B abscesses into a non-antibiotic strategy. And although they did fine, even the authors themselves stated that omitting antibiotics should be limited to Hinchey 1A disease. So I would certainly recommend giving antibiotics to all of these patients. So in conclusion, in patients with acute uncomplicated diverticulitis, a non-antibiotic strategy is safe. Adoption is probably poor, particularly in North America, although we don't have any big data studies looking at this. And my recommendation is that when seeing a patient with truly uncomplicated disease, look for a reason to give antibiotics rather than to avoid them. If you can make a non-antibiotic therapy your default management, in the absence of worrisome features or exclusion criteria like we've discussed, you'll probably avoid a lot of overprescribing. Thanks for listening.